Hello, everyone, and thank you for listening today. At Aging with Dignity, we're talking openly about end of life planning because every family deserves clarity, compassion, and culturally grounded support. I'm your host, Varsha. Those of you who've been following my journey with my parents will know that we ended up receiving support around each of their palliative care transitions. But at the time that we needed it, I didn't even know the services that were available, let alone that we needed it. And quite honestly, I didn't even know what palliative really meant. As I shared our journey through the palliative care needs for both dad and mom, it became quite evident that, in fact, a lot of us don't. In fact, there are a lot of misconceptions around what palliative care is, including palliative care means death is imminent. No, it can be, but people can live months or years with support. You only get it in the hospital. No, there are home, community, and residence based options. It's only for treating physical symptoms. Once again, no. Providing emotional and family support is a key part of palliative care. So, what palliative care is? It's a form of medical care focused on the quality of life for people with serious illness. It addresses physical, emotional, social, and spiritual needs. It can begin at diagnosis and can be offered alongside different curative treatments, not simply as an end of life care. What palliative care is not, it's not assisted dying. It's not giving up on treatment. It's not only for cancer patients or the very elderly. It's not the same as hospice, although they do overlap. And finally, what it should be compassionate, accessible, team based support. It should be culturally sensitive and patient led. And it should be integrated with family and community. So, with this clarification and understanding today, I will be joined by an in home palliative care nurse who helped me navigate this end of life journey for each of dad and mom, both with very different routes, choices, and expectations. Let's begin. Greg, welcome to Aging with Dignity, and thank you for joining us today.
Thanks for having me.
Can you give us a little bit about your background, your training, how you came to the field of palliative care, what your calling was to come into this space?
Sure. Yeah. I got into nursing because I loved working with the elderly. And then when I was in nursing school, I had the fortune of working 2 years at the palliative care unit at the Royal Vic, which was founded by Balford Mount, who worked under Dame Cicely Saunders, who founded the hospice movement in England. So it was an excellent experience. It was a 16-bed unit at the Vic and really showed me how people can live until they die with quality and with dignity and in peace. So I sort of carried that through my nursing education. And then when I graduated, I worked for a year at the Vic on a regular medical unit, and that was during at the beginning of the early 90s, and we had a lot of patients with AIDS. And at that point, HIV/AIDS was a terminal illness, so really working with a lot of people with AIDS who were dying and seeing how we could make that as dignified and peaceful as possible. Um, so always working with either elderly or people with terminal illness, it was just natural to be in palliative care for me. I worked in the States for many years in various nursing homes and established palliative care programs in those nursing homes, seeing that elderly people really, shouldn't be dying in the hospital among machines with people they don't know at the end of their lives, especially people with dementia. They don't know anybody there, and their real home was in the nursing home with their families and their families of choice being the nursing staff. So really trying to advocate for dignified and peaceful deaths at the nursing home versus in an ICU for. So, and then when I returned to Montreal, it was natural for me to work in palliative home care.
Well, I can say personally, you were a godsend to us. From the moment all of this started, it was very similar to what you just said. My dad was in the hospital. He knew he did not want to be in the hospital. He was pulling off all the EKG markers, saying, basically his words of clarity in one moment was, what life is this? Right. So we brought him home and we had him under CLSC care. We had a CLSC home care doctor that came. And I really clearly remember the time when she turned to me and she said, you should probably start thinking about palliative care for your father. And my immediate gut reaction was no. I don't know if I actually knew what palliative care was, to be very honest. Um, but the doctor's reaction was also beautiful. Like she just very calmly said, "Okay, but do you realize you can also do palliative care at home?" Of course, I didn't. So I said, "Okay, how do I do that?" Thinking that there's some special hoops I've got to jump through. And she took it on. She said, "No, I have to write a letter of referral." She did that. It was a Friday. I remember very clearly because her visits were on Friday. Tuesday, you were in our home, and everything really took off from there. So, as I said, you were a godsend to us from that moment forward, right through to the end. Was our experience typical? Is this how people get home care, palliative home care at home?
Yes, so there are a number of ways that a referral can be made. Usually they come from the hospital because people usually have a hospital event that triggers some kind of change. So we often get referrals from the hospital when people are in the hospital or from a hospital clinic, an oncology clinic, a nephrology clinic, a pulmonology clinic, where after a period of time, people are thinking maybe curative treatment is no longer an option or no longer realistic. So, either from a inpatient hospital stay, an outpatient clinic, like your dad, could be a family doctor who makes the referral. Referrals can also come from other sources. We work a lot with Nova. I know you had a podcast about Nova services. So sometimes we get referrals from Nova nurses who say, I have a patient and we really are thinking about palliative, so we can go from there. We work with other agencies like the nurses from the pulmonology center at the Maisonneuve Rosemont Hospital. If somebody has end stage pulmonary disease, sometimes they refer to us. So it can come from any kind of direction. And then once we get the referral, um, kind of as you say, we try to prioritize palliative patients. So we usually are able to turn around the referral within 48 hours, and 2 business days. Sometimes, especially if people are in the hospital, they require services or equipment before they are for them to be able to come home. So we're able to start the admissions process before the person actually is home to put in services in place so that they can go home to be in comfort while they're after the hospital discharge.
Okay. So it really does start with a medical professional making the recommendation and sharing that out. Um, can you talk a little bit about palliative care in general and the eligibility requirements for in-home care?
So, the word palliative palliative care was actually coined by Dr. Balford Mount from the Vic. And palliative in Latin, sort of palliation is to cloak. So we're sort of cloaking the symptoms, covering up things that are not going well.
Okay.
Um, and so palliative is really a control of symptoms. It's really when the decision is made not to cure for, not to treat to cure, but to treat for comfort and quality of life. So palliative care is really looking at more quality of life versus quantity of life. Um, so so I want to talk a little bit about levels of care. There's this document that hospitals use, and there are 4 levels of care. A and B are really people who want to be cured or treated for whatever illness they have in order to live longer. So, in terms of a person, say, with cancer, it would be they're actively pursuing immunotherapy, chemotherapy, in order for them to live longer and maybe even be cured. Levels of care C and D are more the palliative. C is you really. not treating to be cured, but treating to be comfortable. So you could have palliative radiation if you had cancer. It'd be radiation not intending to cure the cancer, but to relieve swelling, which may cause pain or discomfort. Or if, say, somebody has a urinary tract infection, we would treat that because it may be uncomfortable. Level D is really let nature take its course. If you have an infection, let's treat the fever with Tylenol, but not treat the underlying infection. So there's those four levels. A and B are usually not palliative. C and D are. So that's kind of the distinction.
Okay. And eligibility for in home?
So somebody can be on palliative care for years. Um, a lot of the time, people with progressive neurological illnesses, dementia, multiple sclerosis, they can elect for palliative care that they do not want any aggressive active treatment for the illness, but they could live a long time.
Okay.
For the CLSC palliative care home program, usually the prognosis is 3 to 6 months of life if the illness runs its usual course. Predicting life expectancy is a little easier with people with cancer, just because, we know a little bit more about there's usually diagnostic testing that's done and how, what the stage the cancer is, and we know a little bit more about the traditional progression. Other illnesses like end stage renal disease, kidney disease, end stage heart disease, lung disease, those are a little bit more different. So, and difficult to prognosticate. But we go by sometimes we take a chance. So somebody with early stage dementia, say I'm palliative care, they they will not be eligible for CLSC home care as they're probably going to live a long time. The goal of the CLSC palliative care program is to provide more intense support for patients and families who want to stay at home and to be able to stay at home. And so that some of that support that we can provide, as obviously a physician who can come to the house, nurses who come to the house, occupational therapy if we need assistance in helping to choose equipment or positioning patients, and occasionally a social worker as well. Um, we can provide equipment, hospital bed, lifting equipment, those types of things. And we can also provide aid services. So if it becomes more difficult, just activities of daily living, getting out of bed, dressed, help with showers, we provide aid services for that. And those hours are a lot more than traditional regular home care would be. Again, for the purpose of we know that there's sort of short-term intensive services to support the person and their family as they're heading towards the end of their life. Um, it's not necessarily that if you live longer than 3 months or 6 months, you're kicked out of the program. It's if we see that a progression of the illness, there's no plateau, that the illness is progressing. And, I've had patients on the program for a year and a half, but they started out needing the support, knowing that they weren't, electing any curative treatment, and just they lived longer than we thought they would, which was fine.
Okay. That's yeah, I remember you explaining some of that to me as well, and that yeah, it's heartwarming to know that, okay, there's an end date that's kind of stamped on your loved one, really, essentially, at least by CLSC. So, the doctor issues a referral, you go through the ABCD choices. There's some and I remember also doctor going through, sort of that explaining the same thing that you did, that if it's cancer, it's a little bit more precise. My dad had a cardiac failure, so that was a little less so. My mother with the cognitive issues and dementia, even less so. So we were taking everything with a little bit of a grain of salt. Um, but you said really it's 3 to 6 months for in-home care. But I think you said you can also elect for palliative care and you like an early stage dementia. Where would they get that palliative care treatment from? Not in home. So would that be in a hospital or
Well, a lot of the time, if it's at the beginning stage of an illness, they don't need a lot of care. that if somebody it's early dementia, they're still able to trust themselves, there's not or somebody with a sort of, early, like, multiple sclerosis, they don't need a lot of assistance, they don't have a lot of symptom burdens, so there's not a lot of clinical interventions that they may need. So I think that's when the disease progresses and there is more of a need both for assistance physically, symptom management, and emotional support. That's where the sort of more intensive home care services would be.
Very good. And I remember, I mean, you actually talked to it. So 48 hours is a typical turnaround or 2 business days, which was our experience, and, that's really heartwarming to know because when we're making these choices, I'm sure I've spoken to many that are facing it or have faced it recently, and they said, "We waited too long."
Mhm.
So I'm sure once a decision is made to do so, to get that care in home, the fact that you can work quickly is appreciated, and everything moved so fast after you came on the Tuesday. The Wednesday, we had the hospital bed in, we had mattresses in, we changed mattresses for my father's, weight and situation, we already had the lift in for mom, but we were able to get the adjustments on the sling for dad. So a lot of things were happening, the occupational therapist was coming. You've talked a little bit about those services. These are typical services then that are able to come? Okay. And do we as families need to say, "Hey, I need this," or is that part of a checklist that you as a nurse come in
Yeah.
and are able to identify?
Yeah. So everybody's journey is different. So what I like to do is do the initial visit with the physician and sort of go through, what are the issues? What are the symptoms? What are their goals? What is the patient's and family goals of care, the levels of care? And what do they need to support their goals? So if their goal is to stay at home as long as possible, then we go, okay, this is how we can do it. We can bring in equipment, we can manage medications, we can provide aid services, whatever they need to stay at home if that is their goal.
Okay. And we did have Nova, you mentioned them as well, and, that was a lifeline. In many, many ways. So if I just focus on my dad, they were there more towards the end, but the end came very quickly for dad, right? Dad was very unexpected and very rapid for us in our terms, at least. I'm sure there's others that pass quicker, but dad was about 3 weeks. Had the Nova nurse come in, was explaining things to me along the way. Um, did the butterfly for dad, showed me how to administer the medication. But they were also available at the end of a phone, right? They were really when I was confused, when we're confused about the medication, can we put them both in the same arm? Do we have to alternate? Simple, simple questions, I'm sure, for anybody who's even remotely in the medical profession. But they were confusing to us at that moment. Um, I had dad had passed, and I'll just do a shout out to Nova because dad had passed away, and we had an issue on Christmas Day with my mother's hospital bed. Christmas Day, it was in a flat, high position. So I was trying to find out how can I get someone in to help basically maintain that and fix it. I ran out of options of where to call, and I called Nova, and they actually helped me. The biggest thing that they did was they calmed me down, right? That was really amazing. But I'll remember that the Nova nurse was here, and even at the point where, it was dad's final days, so gently that she suggested that now is the time to call, and I wasn't thinking. I don't even know why I said things in the way I did about who I need to call and how I need to and she was advising me on who would make it here, who might not make it here given the time and distance. So that was an immense, immense resource for me a very short time, right? But very intense and very needed. So it's wonderful that you work with the Nova nurses as well. Um, can you explain how that works in terms of getting the Nova team there, getting other services that are required at that stage, and the process that you follow behind the scenes to get all of this going for us?
So as I said before, sometimes we actually even get the referral from the Nova nurses, but usually it comes from the hospital. Sometimes the hospital refers to us and Nova, but most of the time they just refer to us, the CLSC. Sometimes if If the referral comes to both Nova and us, sometimes we actually do the admission visit together, the Nova nurse and myself, the nurse, the CLC nurse, and the physician. But a lot of the time, it's just myself and the CLSC physician, and then we determine, I would say 95% of the time, we also then ask the family if we could involve Nova. I tend to frame it as it's really an additional layer of support. What Nova doesn't have is like the CLSC has the physician, the CLSC has the occupational therapist, the CLSC has the equipment, the CLSC has the aides. So we are the CLSC nurse is the coordinator of care, and the Nova nurses that we work closely with, sometimes we share visits. So I'll go 1 week, they'll go another week. Um, the really great thing about them is that they do have on-call nurses in evenings and weekends. So that is a great resource, but, we work sort of hand in hand, and if I'm busy and I can't get to a patient who's having in distress, then they'll go. The reverse is true. So we kind of just sort of, really, it's a wonderful partnership and a great resource for our patients.
Patients. So, you actually mentioned the beds and all of that, all of the equipment that comes in. It's CLSC equipment, but it's not the same team that we would get through normal CLSC support, or is it?
So it can be, yeah.
Okay.
It's just we ordered, so they can get it from regular home care from
Okay.
CLSC. It's just easier and faster for us to get.
It was faster. That's what we found. Yeah. Yeah.
A couple of the other things that we also can do to help support families and patients at home is we usually order an emergency medication.
Right.
So you never know what's going to happen. So we like to have emergency medication, something for pain, something for anxiety, something for nausea, something for agitation. And it's a box that we order that just sort of sits there. Our whole philosophy is we want to avoid a crisis. And so we have a lot of contingency plans, and this medication, is just available. And if during the day, during the middle of the night, something happens and a physician can't get there or we can't get medications in on time, they're there for us to quickly act so we can control whatever symptoms the patient is having. Another resource that we have is that we can sort of coordinate other benefits that sometimes families aren't aware of. So, say, for example, if a family member is really stressed and working and, really trying to juggle a lot and needs some time off work, there is a program, a Canadian government program called Compassionate Medical Leave. And I think it's 28 weeks out of a 52-week period that if a family member is caring for someone who has a serious illness and at risk of dying, then they can get these unemployment benefits, and our physician would complete those forms. If a patient needs a handicap parking sticker, we can, complete those things. So again, any kinds of resources that people need in order to sort of stay at home. We sometimes talk to family members about referrals to support groups. If somebody's caring for somebody with dementia, then we met the Alzheimer's group, support groups in the Montreal area are wonderful. There's cancer support groups. So, just helping people to also connect to other community resources to help them through the journey.
You become a turnkey resource for the family. Um, all those services are changing rapidly in the marketplace. So, how do you stay on top of everything? Are there courses that you have to attend? Are there just information bulletins that you get? Just curious how you. I mean, there's new grief groups coming up. There's new potential services. Is that just a? I'm just curious as to how that gets
Yeah, I think
communicated.
we just communicate amongst ourselves. Oh, I heard about this, or there's, say somebody wants a pedicure, like at home, or so I might ask somebody, "Hey, do you know somebody does foot care at home?" And then we start collecting make a list of people who they could call, and we provide those to family members if they want their hair washed at home, things like that, that people don't think like, "How do I access these services?" So we can help guide them in resources that they could use.
So there's a network of your nursing team that collaborate together as well,
Mhm.
sure, okay. So in mom's case, um, we started very similar to dad in that we had the doctor do a referral. She basically was evaluating mom, said the same thing. I think it's time that you consider palliative care. And my initial reaction again from my mom was no, but thank you. And then again, we said, well, let's start it at home. So there was, of course, there was more awareness this time. So, but I think I was in a little bit of denial that mom was as far along, and she probably wasn't because, or her journey was different. Dad's was very rapid, very intense. Mom's was longer, um, uh, more gradual decline. But we were very fortunate to have you come in again um, and started that process with mom, which, as I said, was a longer one. In fact, you and I talked at one point and we said, well, you could come every week. Like with dad, you were coming twice a week, thrice a week. Um, with mom, we decided, hey, a phone call once a week was fine. And we would see and change that if we needed to. Um, and then when things changed, they changed very quickly and started to go downhill very quickly. And Teresa Deller Palliative Center was introduced to me again, both by yourself and the doctor, the home care doctor. Um, and it was interesting because in dad's case, I signed it like an insurance form, and I give you credit for that, if it's credit is the right word. Um, I had originally said no, and I think it was a couple of days later you came back and pointed out again very gently, Varsha, I understand you want your dad to have the care at home. We're going to do that. What happens to your father if something happens to me? So I signed that paperwork like an insurance plan, really. For mom, I understood it better. I signed it right away. Um, and so when it came to that time to get mom sort of moving in that direction, it was very quick. Um, I reached out to you. I had some questions about the palliative center. I will be doing a session on Teresa Deller and other palliative centers as well. But can you help to explain? Because for me, again, that happened very quickly. Again, it was a Friday that I made the request to you, and it was on the Wednesday that you were able to call and say, "We've got a spot for your mom the next day." Can you explain from a palliative care nursing team's perspective how that happens?
Yeah. So again, we like to avoid crisis. So we want to be prepared and give people option or make sure people have options. Most of the time in the initial visit, even if people are walking around and their whole goal is, I'm going to be at home, I don't want to go anywhere, that's great. And we will support people to stay at home as long as possible until their death, if possible, if that's what they want and we can do it. Sometimes it's very difficult for somebody to die at home. If if the sort of end stage is very long, family members can rally for a week or 2, but if it's a month, 2 months, 3 months, it's exhausting.
Yeah.
And, family members have to, most of them are still working, childcare, and it just becomes really, really tiresome. People, sometimes panic a little bit. There's these symptoms. It's hard. It's doable, and some families do it wonderfully, but sometimes it's very difficult, and what I always so we usually fill out the initial paperwork for Teresa Deller right at the very beginning and just say, "We're opening a file, and if we never use it, that's fine." Um, and as time goes by, we see how the family's coping. We put as many services as we can in place, and then if we see the family kind of struggling, especially if there's limited family members around, it's challenging being the pharmacist and the cook and the nurse and the chauffeur and, you know, family members wear lots of hats and they sometimes forget to wear the hat of the daughter or the son or the spouse. And so that's sometimes when they'll say, I think it might be time to maybe consider, going to Teresa Deller, where they then become the pharmacist and the nurse and the doctor and the coordinator and the housekeeper and everything. And you get to be the family member. And it's kind of, there may be some guilt involved in placing somebody in a palliative care residence, but almost everybody that I have referred there said, after their relative has died, said, I just wish we would have done it sooner. The care is that good and the burden, it comes off of them. And so that they can really be sort of more present during the process with the family member. So,
Um, yeah, you touched on so many points there that we'll definitely delve into in more detail. So we had for our situation very different experiences of palliative care for dad and then mom. Is there anything that you can think that families, when they're embarking on palliative care, they're not really aware of what they should ask for? Are there legal requirements of what they should be tending to, or um,
well, so let me talk about, so there's palliative home care.
yeah,
If people want to come home, we spoke a little bit about the palliative care residence.
yeah,
There, I also want to talk about palliative care services in the hospital because a lot of the times that people are at, say, an oncology clinic and receiving chemotherapy, and if they're thinking, I think people can need to realize there are palliative care teams in the hospital, and a lot of the times we get a referral, and the palliative care team is already seeing those people either for symptom management, and I always like to encourage patients, if they're thinking about palliative care, talk to the hospital care team, like both inpatient and if you're going to a clinic.
okay.
So to help, talk about symptom management, talk about levels of care, so that when they come to this, they're already sort of started along that line of thinking. So I really encourage people to, if they're thinking about palliative care and they're in associated with a hospital, to access the palliative care team at the hospital as well. I know that you're probably gonna do a podcast about medical assistance in dying, but again, we like to give people options, and we do say to people, if medical assistance in dying is a possibility, are you interested? Some people flatly say no. Some people come to us saying, "Yes, I'm interested and I wanna start the process," and some people haven't really heard about it and they're, we discussing a little bit. Again, it's just kind of sometimes people ask for the consent and the referral process to start for medical assistance and die, and they never use it, right? But it's just an option should they want it. So some people just like a lot of options on the table.
Right. And yes, we will be covering that in a future episode. I think there's a lot of confusion, a lot of unknowns around medical assistance in dying. I know it's legal. We know it's here in Canada. There's a lot of religious thought around it.
Mm.
So we will be having a separate session on that, and yeah, that'll be a very, very good topic, I think, as we delve into that stage of choice.
Yeah,
Yeah.
I wanna get back to your question of what do families not ask for? So, I think the focus is so much on the patient that they forget to ask for, "How can I be helped? How can the families be helped?"
Oh, that's never on your mind. It never is, honestly. So speaking firsthand.
Right, so that's where we come in, and that's when we say, "Listen, you need some support too." The whole focus is on when's the next, medication due, when's you know so we have to come in and say, "Listen, you need to look after the caregiver needs to look after themselves to continue to be caregivers." So we do, along with the aid services that come into the home, to provide the physical care for the patient, we do have respite hours, and I know that Nova had said that as well. So we have aides that can come in 3 hours a day, twice a week. If you need to go get your hair done, if you need to go shopping, if you just need to go take a yoga class, if you need to take a walk around the park, just something to sort of clear your mind that, you're not the caregiver for these specific hours. Again, support groups, that they may want to talk to somebody, who's going through the same difficult time that they're going through. So I think that people need to remember that they need help too. We nurse the entire family. The patient and the family is our patient. And whatever we can do to support the caregivers and then being able to support the family member, and they need to remember that they need support too, and it's not a weakness, it's not taking anything away from the care that we're giving the patient. It's just for the benefit of the patient as well, if they're well looked after.
Yeah, I don't think it's about, at least speaking firsthand or even on behalf of my father, who is caregiver to my mother. It's not that we feel that we're taking away from the patient. It just doesn't occur to us, right? That, oh, I should be taking care. And when you pointed out that, hey, you need to be strong so that you can be strong for your mother or for your wife or spouse, then of course we would say yes, but then we don't necessarily do anything about it. And when I got respite blocks for my father, there was a lot of resistance for the first block that I got for him. This is when he was caring for my mom. And it was a respite block through CLSC. And we were fortunate enough to get a 3-hour block, and he was, "What am I gonna do?" I said, "Dad, you can go for a walk." At that time, he was driving. "You love to go for a drive down in Lachine by the waterfront. You can go for a walk. You can, meditate. You can go on the computer. You can do anything you want. You just don't have to listen out for my mom calling your name." "I don't know," grumbling, grumbling. Well, fast forward, we got it, and fast forward a couple of months, and I was able to get another block. And I said, "Dad, I might be able to get you another block of 3 hours. Let's see if we can do it." No hesitation. "Oh, can we you think we can do it on Friday instead?" Like, he understood the value of it. And it's interesting because at the palliative state, it's even more intense. Um, I certainly was not paying attention to me. Um, and I think this is where community needs to step in because most caregivers, from what I'm learning, are so invested in giving care to their loved one. They're not thinking about themselves. Even if you point it out, it'll be, "Yeah, yeah, I'll do it." But someone to just come, community member come and say, "You know what, Versha, I'm gonna sit with your mom for a couple of hours, go. You did it for me, and I'm sorry I'm crying. But you did it for me when you left, every time. Um, you were you were so respectful with my father that you spoke to him, not above him, not to me about him. So there was that dignity in how you interacted with my father. But every time you saw me, you asked me, 'How am I doing?'" And, I'm so sorry. Um, these were meant for the guests. Um, but it meant a lot, and it got me through some tough moments just knowing someone saw me. I think that's what it was. Someone saw me. I didn't need the accolades. I didn't need the thank yous. I didn't need the "Great job, Versha." I'm doing it because I love my parents. Um, but knowing that you're not invisible and that somebody out there might actually be concerned enough to say, "Take care of yourself," right? Wow, I didn't expect that. So sorry. But I that actually brings me to a point on you and your colleagues who do this. Um, I've often thought, and I think I've actually asked you, I don't know, I've definitely you found your calling. My one description for you has always been you embody compassion, with grace, with such dignity in everything that you do when from the moment you walk into the home until you leave, and you're with families until the loved one passes. I presume it's you from start to finish. They're not rotating nurses in at that stage. I don't know how you do it. I don't know how your colleagues do it. Um, how do you do it?
So, you know, my friends often say it must be so depressing. And it's not depressing for me. It's sad sometimes. Sometimes I cry along with the patients and family members. It's human. It's a sad time. Um, but for me, it's not depressing just because it's such an honor for me to get to know somebody and families at such a vulnerable point in their lives. And I probably have about 60 or 70 of my patients who die every year. And I go down the list of names and I can put a face and a story behind every one of those names. Now I go to a party and I shake somebody's hand and after as I'm releasing, shaking their hand, I forget their name,
Yeah.
you know. So it just shows how much of an impact they have on me and how enriching it is for me to know people's stories and to get to know them really at a critical time in their life. Um, and knowing that, sometimes my impact is big, like somebody's having a lot of pain, we can quickly relieve the pain and, so that's instant like gratification that I get. And then sometimes it's just very small things like, asking how you're doing, and knowing it has an impact. And that's why I'm a nurse. And that's what fills me up. There's a lot of things that drain me and that's what fills me.
And that's what fills you up. That's beautiful. And in keeping with obviously your personality and character. Like these are traits that you embody. So you've certainly found the right profession for the love and grace that you bring to it. I think our listeners, hopefully, for those that are facing this or may face this in the future, that the whole idea of palliative care at home. Let's focus on that for today. Um, are there any last guiding thoughts that you would like to share with them?
Just in terms of death and dying, um, in the 1950s and 60s, we really medicalized death. We medicalized birth and death. Before, people were born at home and people died at home, surrounded by family. In the 50s and 60s, big hospitals were built, and all of a sudden, people were now being born in the hospital and dying in the hospital. And so it really became almost a mystique or even a taboo, like, oh, somebody's dying, don't talk about it. In the hospital, they had visiting hours, no children, people just went there and it was like this mysterious and they didn't come home. So I think people still have that. And it's, there's jokes, it's like there are two things certain in life, death and taxes. And that like nobody gets out of this alive. It's gonna happen to all of us and we're so afraid of talking about it. So I think, you know, um, really I know in your initial podcast that by talking about advance directives and what are your wishes, and I think it's difficult for people to broach that subject with parents, with spouses, um, but however we can try to normalize that,
Absolutely.
and especially for older people, they're thinking about it. you know, we might try to be protective of them, and they might try to be protective of us. So we don't want to, worry them. But people are thinking about it, and just talk about it. You know, I once had a patient and his wife. One of the things I usually ask, kind of most of the time during my initial visit, depending, 'cause everybody's sort of at a different stage, but I usually ask, had you made funeral arrangements? And, you know, a lot of people say, yes, 5 years ago, prepaid everything, I know. And then other people, it's like, well, why?
Yeah.
Like, why are you asking that? So it's really just sort of help prepare to say, sometimes people are just so focused on the details and stuff like this is what medications are on this, and they're not focused on what eventually is going to happen and looking at the bigger picture. So that's why I kind of plant that seed. Also, just practical things. Again, you want to avoid a crisis. You don't want people to make decisions during a crisis. You want it to sort of be done before. But I was speaking with I had a patient and his wife, and I spoke to them separately about, arrangements. And the patient said, "Oh, I can't speak to my wife about that. It'll upset her." And I spoke to the wife, "Oh, I can't speak to him about it. It's going to upset him." So it was almost like a marriage Chrysler. And I was like, "Well," so I said to each of them, "Do you mind if we just like have a conversation together?" So I did, and it was funny. It was literally funny because he said, "Well, I really want a church, funeral." And she was like, "What? You never go to church? Why would you do that?" So they were. It really created open communication and kind of like took away that taboo of we can't talk about it because it's something that we don't that's bad. So Um, just encourage people. It's hard. They're hard discussions to have, but as people are getting, towards the end of their journey, family members want to know what they want and how to provide that for them. So,
Yeah, you've hit on some really good points there because I think that's why we're doing the podcast, right? To get people talking about it, get rid of some of those taboos, normalize some of these conversations, and you did that with dad. Like I remember you came in and you asked him, and it shocked me, but you asked him, Mr. Butt, do you want to live? He was like, yes. And it shocked me because I had some other discussions, which was leading me to believe, no, he's ready to move on. So, um, and that was beautiful because we could have that. And I remember you telling me all the things that all the scenarios that we're asking him questions about would change. His answers would change over time. We were able to do that with dad. We were not able to do it with mom. We tried. right? But we didn't know how much of the cognitive abilities were working. And she certainly was not able to verbalize. She was basically down to yes and no at that time. And sure, she could say yes and no to a question if we posed it correctly, but we didn't know if she'd really understand it with her dementia. So I think really families talking about it, as you said earlier, while you can, while you can share your wishes, while you can convey them to the ones who are going to have to act on your behalf, your family, your loved ones, is so, so important. So I think that's a great point that you've raised here at the end.
I have one other thing.
Of course.
I just want to sort of end with people kind of say when palliative care is approached, either in the hospital or in the home, it's like, oh, this is the end and they're going to stop everything.
Yeah.
And I just want to really say that palliative care is not stopping treatment, it's changing the treatment. And a lot of the time, there are many more interventions in palliative care than not palliative care. So I just want to make sure that people understand that there's a lot that we can do for the patient and the family. It's not like we're going to stop everything. We're going to, you know, it's just a change of course, and the focus is not on curing; it's on comfort. And there's a lot of things we can do to keep people comfortable, and a lot of interventions that we can do. Um, and sometimes the interventions are holding somebody's hand. You know, it's not heroic things, it's, but a lot of them are very simple, but very meaningful and very intentional.
Absolutely. And I think you're right, 100%. There's, things that I saw done for dad and mom at home and at the palliative center that, uh, uh, was all about pain management, right? Really making sure that they were their most comfortable, um, the most at peace at the stage they were at, and the stage changed week to week, day to day at the end. So excellent point. Excellent point. Greg, you have been amazing, not just here today at the podcast, but in my time with you, over the two palliative care treatments we've needed. Thank you is it just seems so insufficient words, but it's the only words we have in this language to express the gratitude that we've got, and so I thank you once again for everything that you've done.
It's been my honor to know you and your parents, truly.
Palliative care is about living well, not dying fast. And in Quebec, there are options, but you need to ask early. So, can you do palliative care at home in Quebec? The answer is yes, but it's not always easy. And it's not always the right choice. For many families, caring for a loved one at home during their final chapter can feel deeply meaningful. I can attest to that firsthand. It offers familiarity, closeness, and a sense of control. In Quebec, we're lucky to have some form of support in place, like palliative home care through the CLSE system, access to nurses, equipment, and even on call medical teams in some regions. But the reality is, home isn't always the best or safest place, and that's okay. If symptoms become too complex, if care becomes too physically or emotionally demanding, or if the home environment just isn't set up to support a peaceful end of life experience, then stepping into a residence, a hospital, or a hospice is not a failure. It's another form of love. Dignified, compassionate palliative care is possible. Preparing for this part of the journey isn't easy, but if done, it can make the process clear, understood, and provide a framework to follow a loved one's wishes and not make decisions for them. And like so many of the topics we cover here, it starts with open, honest conversations, knowing what your loved one values before you're in crisis. As always, I encourage you to check out the Care Toolkit for this episode. I've included lots of resources and, of course, a few action items to get you started on this leg of preparation for your family. Aging with dignity means making choices while we still can, and letting them be known to those who would be responsible for making sure your wishes are followed. If you found today's chat insightful, I invite you to stay connected and share this episode with loved ones. And don't forget to hit like and subscribe to this podcast if you're enjoying what you hear. Thank you for listening in and sharing your time with me. Please join me each week for new insights into aging with dignity. Until next time, reminding us all to age gracefully and live vibrantly. Everything you've heard today, just real talk. It's just our personal stories, experiences, and honest opinions. This podcast isn't providing legal, medical, financial, or therapeutic advice. And no, listening doesn't make me or my guests your lawyer, doctor, financial advisor, or therapist. The guests and I are here to share stories, spark ideas, and hopefully give you something to think about. When it comes to the big decisions, make sure you do your homework or check in with the experts who know your situation best. We're here to keep the conversation going. You're the one in the driver's seat.